I love the term can of worms because there's always this sort of analogy that I teach my trainees about a man who comes in with a can of worms and he goes, "Doctor, I've got a can of worms." And the trainee has basically three options. They have the option of firstly ignoring the can of worms and going, "I didn't see that can of worms. Let's talk about something else." They have the option of, "Okay, let's open up that can of worms. Oh my goodness me, I'm getting eaten by about 1 million worms here." Or they have the option of saying, "So I can see you've got a can of worms, and we may not be able to deal with every single worm today. I can tell you what we're going to do in these 10 minutes is decide upon the juiciest."
Today I have a special guest on Success Inside TV podcast. My guest has previously been on the show, and this is Dr. Giam. He is a TPD for the St. Mary's BTS, a trainer, and a previous RCGP examiner. Welcome to the show, Nigel.
Thank you so much, Owen. Really nice to be back. Very nice to see you again. So thank you for inviting me.
Nigel, you have been very experienced in this video form of consulting because you set the video consulting yourself when you were in training. Could you tell us a little bit about that?
So prior to the new MRCGP, the old MRCGP was not actually a mandatory exam, as you may be aware, and we only had to pass something called summative assessment, and video recordings were actually part of that. But if you wanted to attain the MRCGP, which was really sort of deemed the exam of excellence, then your videos needed to be of a higher challenge and a higher caliber. And actually, interestingly, in the old MRCGP, the video component was the component that most STs found difficult in passing. So it only had a pass rate of around 70 or so %. And we were given quite a lot of time to get our recordings together, 3 months, 7 consultations, 15 minutes each. And specifically, we were told to cover certain types of curriculum areas. Now, I suppose going back to my own training, my sort of nightmare around this was I went on an RCGP course, and this was back in, I think, around 2001, 2002, where I took my videos, and this just shows how old I am, on a VHS tape up to the college to show them and to have them marked. And I took what I thought were my 7 best consultations. Volunteers were asked to showcase their consultations, and I showed a consultation with a very anxious mum and a child. It was face to face, and I thought the consultation went really, really well. And at the end of that calibration, the senior examiner at the time said to me, "Well, it's clear you're very nice with patients, but you have no idea what we're looking for here in terms of actually what we're assessing. So this would not be a case that you'd be able to submit." And that absolutely shocked me to the core, because at that point I only had about 10 days left for submission. But actually understanding those rules really then made me recognize that to pass this, you have to be very strategic. That is not the same as being formulaic, though. And I think what I've observed now, having marked about 100 or so RCAs to date, and these are for people that I'm mentoring, is that there are a lot of similarities with what actually happens in the CSA and also the RCA, which perhaps we can touch upon a little bit later. So it's a very challenging assessment. The one thing that works in your favor, obviously, is that you are in control of what you submit. You're not necessarily in control of what walks in through the door, but then if you have the right strategy, the key is how do you make that case into RCA worthy?
Thanks for sharing that story, because it's important that the audience knows a little bit of background where you're coming from. And you've actually marked RCAs yourself. And one of the trainees that was speaking this week, Dr. Hamilton, who actually said a lot of good things about the method you actually have with the story, symptom, and then system, was saying that you actually reviewed a couple of his cases and you told him exactly why it was. The cases were not up to the mark, and he took the feedback, and actually he said to me that he passed because of the feedback that you gave him.
I mean, that's really, really encouraging to hear. I think one of the big issues is that one of the similarities in which the CSA and the RCA work is that they're both very narrative-driven exams. And actually, if you think about what we do in general practice, we're trying to manage people as opposed to just diagnoses, and we're trying to manage narratives as opposed to just symptoms. So when I looked at a number of RCAs, and these are for people who are going to submit their cases in the first cohort, what I recognized is that as a tendency, and we touched a little bit upon this actually when we did our first podcast together, is that when you are preparing for an assessment, the tendency is to become symptom driven very quickly. So actually a lot of cues are ignored, patients are coming in, and what's very interesting in the RCA is the patient is very keen to tell their narrative quite quickly. All you need to do is listen and pick up on the cues. The danger is to park cues, because what I've noticed as one of the biggest pitfalls is when STs park cues, they actually miss the main theme of the case of what the patient's trying to say to them. The anxiety, and I've heard this probably about 100 times, is that ST say, well, if I follow that cue, I'm going to lose my structure. I'm going to lose my organization. But actually, structure and organization isn't about you just having a set list of questions, because the RCA is not an OSCE. It's not a tick box exercise. And the tendency, I think, was for people not to actually understand the competencies that we as examiners are looking for, or rather me as an ex-examiner, because I used to obviously calibrate for the old RCA. So you need to firstly understand what it is that we are looking for and what we're assessing you on before you even start recording. Because if you start recording blindly, you're going to get burnt out with this very, very quickly. It's very energy consuming to do this form of assessment. It's so different compared to the CSA, because in the CSA, obviously, you can work in study groups, you can pace yourself. But in the RCA, you burn out quite quickly, because every day you're going in and you're getting stressed out. Am I going to get that right patient? Is that right patient going to walk in through my door? So it's actually more energy consuming than the CSA. So it's all about working smart and strategically.
In terms of the calibration, how does the calibration work for the RCA? Because everybody's seeing different patients and have different clinical cases.
This is really a big dilemma. I mean, I've sat in on a number of HEE meetings. Obviously, my other hat is as a lead TPD, as a chair for ARCP for Health Education England, and I'm based in London, so I've been sitting in on a number of meetings, and this has been a big issue around standardization. And there still isn't a clear answer, as far as I'm concerned, as to how the college are actually standardizing the marking in their cases. Obviously, a lot of the examiners have had experience of marking the old RCA and the video submissions, but they were different criteria. The criteria that are being used at the moment are exactly the same as the CSA. And obviously in the CSA, as the examiner, we have all the information about the patient to standardize the case. Whereas in the RCA, as examiners, we have nothing. You as the candidate have all the information. So in a way, to standardize the case, you have to demonstrate to us what you actually understand around these consultation behavioral competencies that we're looking for. That's the only way in which you can start standardizing what you submit. But the key is finding, I suppose, the right case, because what the college have stressed is that if you take very easy cases where there's no real challenge, then actually you won't be able to demonstrate or standardize up to that RCA 16 competency grid. So in terms of the standardization, it's a very good question. I don't have an honest answer for that, is the honest truth. They are applying CSA criteria to RCA cases, and that's what I've been doing. I've been marking to a CSA standard. And because I'm very clear as to what I'm looking for, you can then apply that to the RCA. And, it's very good to hear that the ST that you spoke to found that a very useful process, because you then become very confident about what you can submit. But in terms of standardization, I mean, I hate to say this, but I think it's really important that you don't sort of just rely on one person necessarily to look at your cases and go, yeah, absolutely, all good, all fine. You need to have your cases looked at ideally by, one or more trainers, and you need to kind of be quite tough with yourself as well in terms of how you mark your cases. Because the majority of people were fine with the RCA in the first cohort, but there were a significant minority who got stung quite badly. And I've had a lot of people coming to me saying, my trainers said that this was fine, that all the cases should be fine, and I failed the RCA by a good 20 marks. So I don't know what I'm doing wrong.
The calibration is very uncertain how we do that, but the marking is clear from the college. So when you're marking one of the cases for a trainee, what do you go through your steps? How would you mark a case?
Yeah, sure. So the first thing to say is, and I've said this on a number of webinars, I'm just going to pull this out, but you've got to have the CSA sort of mark sheets in front of you. And this template I've designed myself based on the 16 competencies. So you'll recognize this because when you came on the CSA course, I marked you as well according to the 16 competencies in terms of the CSA. And now that we have some feedback from the first cohort, we know that the competencies that people are falling down on are the same competencies that were highlighted from the CSA perspective. So actually, if you start focusing down on those competencies, you're more likely actually to help yourself standardize a case and also recognize that these are the deficiencies that you really need to strategize. The first thing that I look at are the global competencies, specifically around organization and structure, and secondly, around recognizing the theme or the priority of the case. I've seen too many RCAs where history is still being taken at around sort of 7.5, 8 minutes because, you know, an ST has forgotten a question and then suddenly thrown it in. And actually, it's had no bearing on where you're going. There's already been enough information to actually move through. The problem is as soon as you start doing that, your organization structure is going to fall apart completely. Organization and structure, as I said, is not about having a set list of questions. I think that the tendency is if you're very formulaic, that you feel you need to ask those questions, it will appear actually very unstructured because you're not actually listening to the patient. And as a result of that, that will compromise global competency too, which is not actually understanding the main priority of the case, the main theme of the case, the main dilemma of the case. What's fascinating is that in the RCA, often the patient will give you their ICE very quickly. They will tell you what they're concerned about. More often than not, there's no hidden expectation or agenda. It's just very much about staying close to that concern and readdressing that agenda. There's been a number of cases I've watched where the agenda of the patient has gone further and further away from the consultation because the doctor is becoming more and more diagnostic. So what happens in the second half is that the patient's agenda or concern isn't addressed at all, actually. And all that happens is that the doctor says, okay, I think this is potentially what the diagnosis is. But, you know, the patient, on the other hand, is still worried because they came in with a preconceived idea that their headache, for example, may have been due to something serious. And that actually hasn't been addressed in the first place. Now, the way that I mark it is that as soon as you get knocked down on the global competencies, it's actually going to become very difficult to become a passing candidate. You're already going to be borderline by default. We know that the marks are exactly the same as the CSA. So you're going to get 3 marks for data, 3 marks for clinical management, and 3 marks for your interpersonal skills, for your IP skills. As soon as you strike out in global competency 1 or 2, it's actually very difficult to score more than 5 to 6 marks out of 9. Because if you look at the pass mark for the last cohort, so we've got 2 examiners at this point in time, and they're each giving you marks out of 9 for 13 cases. So that's 117 per examiner. So that's 234 marks for a whole circuit. And the pass mark was set at 144, which equates to a CSA pass mark of about 72, because you just halve it. We know that the CSA pass mark ranges between sort of 72 up to 78. So this was already on the lower end in terms of the threshold for passing. And a number of candidates, unfortunately, just didn't hit that mark because they weren't focusing on the competencies that have been highlighted, especially these globals, basically. So that's the first thing that I look at. The second thing that I look at in terms of data gathering is making sure that the way in which you're asking questions is in context. Because what we're ultimately interested in is committing to risk. And in order to commit to risk, you've got to recognize something is potentially serious or not serious. And in order to do that, you need to ask red flag questions in context. I've seen too many RCAs where questions have just been thrown out to patients around, for example, family history of cancer, and the patient has become incredibly pensive when they've heard that word cancer because it's not been signposted. You know, the thought processes haven't been explained. The other thing to mention is that the examination is part of data gathering. So I've seen a lot of cases where the ST has simply said, well, in order for me to manage you, I firstly need to examine you. So let's bring you in for a face-to-face, and then we will decide what we're going to do. If you do that, then actually, guess what? You're not going to get any marks for your clinical management section because the examination is actually part of data gathering. So that is a massive pitfall that people have fallen into. So data gathering includes the examination. And when you are starting now to think about clinical management, it's competency 10, which is key, which is committing to risk. Again, I've seen too many RCAs where the tendency has been to sit on the fence with blood tests and sort of say, well, let's do some blood tests and then we'll see you again in a couple of weeks and then decide what we're going to do. You're not going to be able to pass a case if you don't propose what you're doing those blood tests for or what you're doing that examination for. The behavioral indicators that have been stipulated for the RCA is that you have to justify why you're doing these things. So if you look at the clear pass and passing indicators, the word justifiable is highlighted twice. Okay, are these actions justifiable? Why are you bringing in this patient face to face? What is it that you're looking for? So, for example, I've seen a number of cases where patients have presented with potentially IBS type symptoms, and obviously we're going through a period of stress with the lockdown, so it's not uncommon to see sort of gastric upset. So I saw a case recently where, you know, the ST said, so I'm going to bring you in, I'm going to examine you, and then we'll do some blood tests, and then we'll see if it's IBS or not. And then that was the end of it. Now that's not going to be enough to pass. What you need to be saying is, well, firstly, you know, because the patient themselves, actually, their first opening statement was, I wonder if I've got IBS. And what the ST should have been doing is saying, well, okay, I understand you think it might be IBS, and then just being curious. What do you understand by IBS? Why did you think it might be that? And have you read around IBS and how we might take it forward if it is IBS? Because you can get the patient to do a lot of work for you if you open up their health agendas. Because in that second half of the consultation, what we're expecting to happen is for the ST to be saying, well, firstly, there's no diagnostic test for IBS. You know, IBS is a diagnosis of exclusion. And a lot of your symptoms are suggestive of that. But before we label it as IBS, we do need to do some blood tests just to make sure there's nothing else that's causing your bloating. And then you've got to talk a little bit about what the tests might be. Again, it gets very technical. This goes into the interpersonal skills where people are just saying, I'm going to do your full blood count. I'm going to look at your hemoglobin. I'm going to do a celiac screen. You know, and yesterday when I was listening to this case, the patient was saying, well, what's a celiac screen? So your actions will have reactions. You know, there are different ways of phrasing things to say, well, you know, there are a few important tests that we need to do. We need to, you know, look at your blood count to make sure you're not anemic. There are some markers of inflammation that we can do to see if there's potentially some inflammation in the gut that might be causing this. And also there's a particular food intolerance that we can test you for around gluten, which can sometimes mimic these symptoms. Now, if all of those results are normal, then there are quite effective treatments for IBS, which we can start talking about. You know, and these include modification to your diet and also some symptomatic treatments according to the symptoms that you're having. And yours is specifically bloat. Now, if you start committing in that way, then you're going to get more marks in the clinical management section because you're beginning to move forwards with what you're proposing to do. But if you simply stop short at just saying, I'll do some blood tests, see you in 2 weeks, and then we'll talk about it, that's not really going to be enough to cut the mustard, basically. In terms of the interpersonal aspects, the main thing really is picking up on the cues. And the tendency is I've seen too many STs, parking cues. And what's very interesting is that when you do a CSA, the simulator is only allowed to drop a cue, usually only twice. And what I found fascinating with the RCA is the patient does that as well. They've actually said something twice. And then when the doctor has chosen to ignore it, it just doesn't go away because it doesn't come back, basically. It just doesn't come back. So it's so important not to park cues. If a patient's trying to tell you something, it's because they're worried about something. So the cue really is king in both the narrative, the RCA, and the CSA. So the biggest mixed message is if I follow this cue, I'm going to lose my structure. No. If you don't follow that cue, what's going to happen is you're going to become incredibly diagnostic and doctor-driven. And knowing that this is a patient-centered exam with regards to how to listen and react to patients, you would be very foolish to park cues. I think the other aspect is recognize that, you know, a psychosocial perspective isn't about just simply saying to someone what you do for work and who lives with you at home and do you smoke, do you drink. There's too many of these questions I've seen asked out of context. What we're trying to do is manage patients. In order to manage patients, we need to understand the psychosocial perspective in terms of the impact that this patient's symptom might be having on their narrative, on their story. So it's very much in keeping with, you know, I can understand you've been quite stressed out with this headache. You know, has this impacted you in the context of, for example, work or outside of work? What has stopped you from doing? And most importantly, how you acknowledge that. So in the interpersonal aspects, a lot of people sort of equate interpersonal skills to being nice. It's not about that, just about that. It's about acknowledging. It's about understanding that, you know, you're not there just to process. So one of the things that I've been doing recently is looking at how people process information in the RCA. And the go-to words are okay, fine, right. And the number of times you say those words out of context, the less you're actually listening to the patient. So I saw an RCA recently where the ST was literally just going fine, fine, fine. So my mum died from cancer. Fine, fine. It's like, it's not, it's not fine. It's not fine. As opposed to, I can see you're very worried about that. I'm very sorry to hear about your mum. Okay, so acknowledging is about I hear you and I see you, empathizing. I'm very sorry to hear about that. But then it's also about energy, which is why I'm glad that you've made this appointment so we can look into your concern. So I teach this sort of acronym on my course, which is AEE: acknowledge, empathize, energize, as opposed to just processing. Because if you end up processing, what's going to happen is you will just end up talking at a patient rather than with the patient. So that, in a sort of a nutshell, are the main themes that I look for in the context of the RCA, in terms of both the data gathering, the clinical management, and the interpersonal skills. And just, I suppose, a caveat about the clinical management is that if we're managing risk, your management has to be reactive and justified to the level of risk that you're committing to. So competency 8, which is about appropriate use of resources, I've seen too many RCAs where there's been over investigation, there's been over referrals, and there have been promises that have been made that cannot be kept to during a pandemic, such as, oh, we're going to get you seen in this clinic. It's like, you're not actually, because right now, there are no routine referrals that are being seen. So you've got to also be realistic of what you can actually deliver within your own area. And that means keeping up to date with when referrals do open up. It's about keeping up to date with how 2-week triages have changed during COVID. If you look at, for example, what the LMC published back in April, I know it was some time ago, but for example, bowel screening, certainly within London, in the context of 2-week waits, everyone had to have a fit test before they referred. So to just sort of go, I'm going to refer you on a 2-week wait without actually escalating that and investigating that is not going to reflect currently nationally accepted practice. So you've got to be clear about what you can do and what you can't do. And there's a difference between reactive clinical management, which is reactive to risk, and risk-aversive clinical management, which then becomes defensive, over investigations, over referrals. But then the flip side to that is making sure that you're safe, and not missing something which is potentially serious. So I've seen a lot of assumptions made in the RCA where, a patient has suddenly been labeled with a diagnosis, and actually the red flags haven't been asked, haven't been listened to. So just got to be slightly careful with that too.
What you're referring to is the competencies and the feedback that the candidates would get from the examination. There's also one of the table that I've seen, the coded consultation assessment tool, where they have these 3 columns. I'm sure you've seen that. I'll show it to you.
Yeah.
So this one, is it the one that's more global? And do you think that one is based on the competencies? Yes,
it is. It is. So when you have a look at those are the RCA behavioral indicators that are being looked for. But when you actually look at the 14 fish feedback, it is basically split down into these 16 competencies that we've just talked about here. So those are the competencies that are basically highlighted. So the RCA behavioral indicators essentially just flesh out those 16 competencies in a bit more detail. But that as a mark sheet, that RCA mark sheet, is not particularly user friendly. So what I would certainly recommend is using the sort of CSA mark sheet and adapting it slightly according to the RCA behaviors that have been highlighted, which are the ones that we've mentioned.
In terms of what you said with Q is king, I want to go back to that because this is very important. And sometimes candidates might feel that when they're going to go in and dig in upon a queue, sometimes they might be opening a can of worms that's going to make things harder for them. How do you balance that, Nigel?
I love the term can of worms because there's always this sort of analogy that I teach my trainees about a man who comes in with a can of worms and he goes, "Doctor, I've got a can of worms." And, the trainee has basically 3 options. They have the option of firstly ignoring the can of worms and going, "I didn't see that can of worms. Let's talk about something else." They have the option of, "Okay, let's open up that can of worms. Oh my goodness me, I'm getting eaten by about 1 million worms here." Or they have the option of saying, "So I can see you've got a can of worms, and we may not be able to deal with every single worm today. I can tell you what we're going to do in these 10 minutes is decide upon the juiciest worm that you want to deal with, and that can of worms, that's going to sit on my shelf, and we will get through them, but not necessarily all today." So the issue, I suppose, is this can of worms, because if a patient has said specifically a cue twice, what they're trying to cue you into is the juiciest fat worm ever. Okay, and you'd be very foolish to ignore that. Now, yes, I know patients like to talk and often they can go off on tangents, but then it's also about being strategic of recognizing that may not be the best RCA submission. But if a patient has come in with a singular problem and they have said that they're worried about something, or they've cued you into something again, we would be very foolish to ignore that. Okay, because that is the can of worms, and to actually solve a problem, you've got to get into the can of worms, basically. So very, very important. Don't ignore cues, but also appreciate that patients won't make good RCA submissions, because you know they will often go off on tangents. But you kind of know often when who those patients are, and if you recognise that that's already the case quite early on in a consultation, then just switch the recording off and just don't worry about wasting your energy on that one.
I think it's important to look at the strategies, because you're big on strategy and looking at the strategy angle and conserving energy. So when you look at these candidates who are struggling to get the right one to submit, what would you say would be the best way they can set up to put the odds of success on their side?
So there's quite a useful document from HE that's come out today to all senior educators, which I'll post on my Facebook support group, and it will be going out to all trainers and trainees shortly, which specifically highlights that you need to firstly be avoiding follow-ups. Okay, and certainly, you know, a patient that you've seen before and you're following them up will not make for a good RCA submission. I mean, this was highlighted with the old RCAs as well, because if you're being assessed on data gathering, then actually if all the data has been collected in the first consultation, then you won't be able to demonstrate anything in the second. A follow-up will only work if the patient has not seen you before, and the best follow-ups are when you're going through, for example, blood test results which might highlight a new diagnosis or a new chronic diagnosis, for example, diabetes or hypertension. But in order to have strategy, you need to know your place in a patient's story. If you imagine both the RCA and the CSA being a bit like a car journey from A to B. Now, who's driving? You, because it's your test. But right next to your patient, your passenger, they have all the information that you need. In a follow-up, that journey has been started by another GP who's left the car. You're getting into the car. But the patient, they're already in the car. Yes, they want their results. They've been told to ring you for the results. So all you need to do is ask 3 very simple questions and then get going, which is firstly, you know, we've not met before. Can I ask briefly what led you to have the test? What was discussed with Dr. Smith at that appointment? And did you have any particular concerns as to what might be going on, or in terms of the blood test? Okay, in which case, let's go through the results. Okay, I've got your results here. And, you know, the sugar level that we did actually come back high again. I know that Dr. Smith was mentioning a possible diagnosis of diabetes, and I think with the second reading, it does suggest that we're dealing with that. Now, I appreciate that might be something that, you know, you might not have expected to hear, but there are things that we can do to help. But in order to understand, firstly, why this might have come about, can I go back into your story at this point? And then you've got to start thinking, you know, what is this patient exposing themselves to? Because the message with chronic disease is very simple. Chronic disease exists because you are what you eat. So in that story, you need to start finding out what that patient might be exposing themselves to in terms of diet or adverse lifestyle factors or weight. And then you've got to start, if you go symptom system, not just think about the symptoms of diabetes, but the system really is about cardiovascular risk. So start thinking about other cardiovascular risk factors which might require attention. The candidate who doesn't pass is the one who holds on to the results 5 or 6 minutes. And then suddenly delivers the result, only to be left with no time to actually manage with what's in front of you anymore. So knowing your place in a patient's story is really important. And what this document highlighted that came out from today is what I just said at the start, which is that as examiners, we have no information about your patients. If you don't verbalize information in the patient's notes, which will help us understand this patient, if you're not specific about that, we can't mark you. If we don't hear it, we won't mark it. So I've heard too many RCAs where patients have said, so I can see you have some issues with blood pressure and you take a medication. What the examiner wants to know is, what's that medication? You know, is their blood pressure under good control? What was the last reading? Because if you don't share that with us, how on earth do you think we can actually mark you? You know, because we can't. And this brings us back to the standardization aspect, is that it's kind of almost your job to standardize the case for us so that we can mark it in context. Because if we don't have that information, we're going to find it really, really difficult. So follow-ups have to be in context. Okay, they can't be patients that you have seen before. The best follow-up is going to be going through a blood test result. And examples have been, as I mentioned, diabetes. There's also been some lung function tests that I've seen, and also hypertension, blood pressure monitoring. These all make quite good cases, actually, if you have the right strategy, because what it's going to boil down to ultimately is kind of health promotion. So it makes for a good narrative when you start thinking about that aspect of things. The other good cases are patients who are coming in who are worried about something. So patients that you might see in unscheduled care, out of hours. And the reason they're good is because, firstly, you don't know them, which is great as a general rule. They're coming in because they're worried at something serious. So at the end of those 10 minutes, you do have to commit to risk. You have to be seen to be committing to risk in a reactive way. So those cases make for quite good submissions too. I think one of the issues and one of the big challenges now is because we're doing so much remote consulting, you will often see on the original e-consult what a patient might be presenting with. And the dilemma for you is, do I then, open that narrative up, or do I just go in with an open mind? And, it's a bit of a catch-22, because with strategy, what you want to be doing is with the time that you have left, trying to choose the patients that you can see, which might make good RCA cases, rather than just hoping that, that patient is going to come in with a problem that you can work with. And actually, what's interesting is the document from HE has stressed that actually trainees should be allowed to be a bit selfish about sort of picking particular consultations if they're going to have a day of recording, to say, okay, so that looks like a good one. The patient's got a rash and they've sent an image in, or there's a mole that they might be concerned about, or okay, so the patient's presenting complete testicular problem. That's great. Those sorts of cases make for really, really good cases. But, if the e-consult reads, patient wants to talk about this, and this, and there's already multiple agendas, then they won't, because you're just going to get fluxed very quickly, basically.
It might be helpful for the candidate to go through the record and look at a little bit the background of the patient to know beforehand.
Absolutely. I cannot stress how important that is, about actually spending an extra, 30 seconds looking at a patient's notes to think, okay, what information is important here in context? Is there information that I need to use and can use? So, for example, mental health. I've seen a lot of patients myself, but also listened to a lot of RCAs and marked a lot of RCAs where the patient has had a recurrence of their depression because of the situation that we're going through. And actually, from the notes, you can already see that the patient has taken antidepressants before, that they've had CBT before. And if this information is only shared with the examiner at 7 or 8 minutes, then that's not strategy. So I saw an RCA, or rather I marked an RCA where the opening statement of the patient was, I think my depression's come back and I think I might have to go back onto medication. Now, the clear passing candidate will have already looked at the notes to go, to recognize that this is not a new problem, because the patient firstly has already said that, but they've already looked in the notes previously. The clear passing candidate will firstly acknowledge by saying, I'm very sorry to hear that you feel your depression's come back, and I obviously understand that you feel your medication might work again. I'm just having a look at your notes, Mrs. Smith, and I can see that the last time we saw you with your depression was over a year ago, and that you were on a medication, citalopram, which seemed to work quite well. Yes, that's right. So what's been happening over this last year? Everything was fine up until lockdown. Yeah, lockdown's been very difficult for all of us, and I'm really sorry, but I'm glad you picked up the phone, because there are definitely things that we can do to try and help you with your mood. Could I just ask a few additional questions to see how this might be impacting you? So that's what the clear passing candidate will do. The person who's not going to do so well is the person who basically goes, okay, so let's just talk about your mood. How's it affecting you? Let's talk about your appetite, your weight. Let's talk about red flags. And then at 8 minutes, they'll go, oh, I can see from the notes that you had citalopram before. It's like, well, yes, but my opening statement was I wanted to go back onto that anyway. So it's very much about knowing your place in the patient's narrative. And this is the biggest difference between the RCA and the CSA. In the CSA, you have very little information, we have all the information. In the RCA, you have all the information, we have none. So it's a sort of it's a flip. You have to share that with us in order for us to be able to mark your patient in context. The analogy that I've been saying now is that we as examiners, we are readers of your consultation, but you have the book, and it's up to you to populate the book. It's up to you to populate the chapters. Because if chapter 1 is just blank and you already know what chapter 1 is because you've got the information, you don't share that with us, then it's going to be very difficult for us to enjoy your book. Yeah, it's going to be very difficult to enjoy that narrative.
To what extent do you think the workbook is relevant in putting in these details, or just spelling out the details for the examination, what's going on in the patient's case?
The workbook isn't there to fill in all the gaps that you should have asked, is the first thing to say. The workbook is meant as a brief descriptor of the case and the angle that you're trying to demonstrate to us as examiners. But it isn't there for you to essentially record all the patient's notes. It's not there because, it's very busy marking RCA cases. Examiners are incredibly busy and they're not going to have time to read every single detail of your work. And also just recognize that actually we can't validate that, because you could put anything in the workbook and we don't know whether that's necessarily true or false. So if you say, I'm going to prescribe something, and you don't stipulate what you're going to prescribe, and then in the workbook you say, so this is what I prescribed, da 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 da, we're not going to take that at face value, because we need to hear it. You could have written anything, you could have prescribed anything. We need to hear it. If we don't hear it, we can't actually mark it. So if you're going to prescribe an antidepressant, then please tell us what that antidepressant is, because in the CSA you would tell us what the antidepressant is, you would tell us the dose, and you would tell us how it's to be taken, when it's to be taken, and when we might expect a result from it, and the patient would expect that too. But in addition, in the RCA, the patient will often know, where do I pick up that prescription from? So there are other little practicalities that you need to think about, which would not necessarily apply in the CSA.
Yeah, and these practicalities can eat the candidate's time with these logistic questions, especially in telephone consultation. I've noticed that. So do you have any practical advice for people watching?
So I think if you're going to prescribe something, firstly, know where the patient's chemist is. And if you prescribe it, say, this is what we're going to prescribe, and I'll send it to your usual chemist, da, 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 and it'll be ready this afternoon. So just preempting that, rather than sort of saying, so I'm going to prescribe something, and then the patient then saying, okay, will that be my usual chemist? Oh, let me just check your usual chemist. Okay, okay. And when do I pick that up, doctor? Oh, it's this afternoon. So it's, you've got to preempt these little things, because they will save, actually, every second that you save here will all accumulate and aggregate, actually. So just again, it's about sort of knowing your patient before you open that book to start writing those chapters, is recognizing that actually some of the information for you to share with us is already there, and it's for your benefit to use it. It is, because I think one of the issues is recognizing that a lot of the patients that you see for the RCA, they're already differentiated in a number of ways, in terms of the chemist that they use, in terms of the allergies that they have, in terms of the fact that you can see that they don't smoke or they don't drink alcohol, and if you're going to ask lifestyle questions, again, the clear passing candidate will go, so I can see from the notes that you don't smoke, is that still the case? As opposed to someone who goes, so can I ask, do you smoke? No, I don't. Have you ever smoked? No, I haven't. Okay, but I kind of knew that anyway because I saw that in your notes. So again, these things save a lot of time. It's about making sure that you're using information in context and asking questions in context, rather than asking a question to which you already know the answer, which is a waste of time.
I'd like to shift gear a little bit here. So if we talk about the mix of cases and the different format, there's telephone consultation, video consultation, face-to-face consultation. Are you seeing a trend where people are sending more telephone consultation because this is the way that most consultation is being done?
Yes. I think we've all been thrown into a very interesting period where we've all been sort of a little bit slow on the uptake of consulting virtually. And I mean, it's been in talks for many years, and obviously we do some, but you know, the pandemic has really highlighted we've had to move very quickly with the times. And ultimately, I mean, if you just look at what's been coming out recently from the health secretary, he wants all consultations really to be done remotely. So it isn't uncommon at all to submit your consultations in one modality, and certainly the college at this point have said that's okay. I would say that generally you should try and get a spread, certainly of audio and video. And I say video because quite a lot is often lost just from an audio consultation in terms of non-verbal cues and how a patient's looking. And actually, it's quite nice often to see how you're looking and empathizing, because you know, empathy can be demonstrated, for example, in many ways. There's a difference between a comfortable silence and an uncomfortable silence. And if it's just an audio consultation, you know, a silence which might, if it was face-to-face, be empathic, might turn into an uncomfortable silence much quicker. Whereas actually, if you're seeing a patient face-to-face or on video, then that silence, if you've got good eye contact, you know, we will see that, obviously, examiners. We will see that you're trying to facilitate through your non-verbal behaviors the consultation. Again, there are a few tips, I think, over audio to recognize how to empathize. Again, it's about acknowledging what's happening in front of you. So if you recognize a patient's kind of shutting down over the phone, simply acknowledging that. I hear you in particular. I hear you, because you can't see them, but I hear you, and I can hear this has really concerned you. And then again, empathizing to try and move the consultation along. You know, I'm sorry, I can appreciate it's been a very tough time, but then energizing, which is ultimately how you start driving, which is, but you know, I'm glad that you phoned today, and there are things that we can do to help. So you've got to do a lot more of that, I feel, over audio consultations, because there are some nuances that you will miss in terms of non-verbal aspects. I think you should try ideally to get certainly a mixture of audio and video. I think face-to-face consultations are interesting because at the moment, with all the sort of protective gear that we need to wear, and the patient having to wear that too, sometimes I found it quite difficult to actually hear what's being said. So there's often a loss of quality in terms of the audio through the masks and the visors. And again, you know, we're not going to see what you do in terms of examination as a general rule of thumb, because a lot of it will be off camera unless it's a very simple thing, which can be done. But again, you've just got to remember about, you know, hygiene measures and hand washing, and you know, you have to be seen to be doing all of that face to face. It's important. And obviously, if you're in a rush, you may just forget to do that. I've seen a few RCAs, and it doesn't really sort of sit well when, you know, a doctor isn't sort of demonstrating those sort of competencies around hand washing and safety. So there are advantages, certainly, but there are certainly disadvantages too with each modality. I think one of the big issues is if with audio, how do I demonstrate competency 5, which is the examination? But the whole point here is you can still attempt a remote examination even over the phone. You know, I've seen some very successful examinations where you know, patients have been able to take their pulse over the phone or their temperatures. There have been really good video consultations around joints where the doctor's taken the patient through the motions of look, feel, and move. So rather than think about what you can't do, think about what you can do. Okay, because there's plenty of things that you can do in terms of images of skin. You know, these can all be sent in beforehand. So again, it's about being strategic. If you know someone's consulting and the e-consult says they've got a rash, can we get reception to give them a call to send in a picture of the rash so that we've got all the information before we start consulting with that patient? Because the last thing that I want to do is at the end of that consultation go, I can't commit to anything, need to bring you in so I can have a look at the rash, or send me a photo of the rash. It's like, just get all of that stuff beforehand, basically, you know, and that will definitely save time.
In terms of the audio consultation, if you were going to convert that into a face-to-face one, some people might consider this as a triage one where you're not completing the management. Do you think that if you explain the potential diagnosis, what you're looking for when you're going to examine the patient, and discuss a little bit about the management, that still will rack up some of the clinical management score and be able to be submitted?
Definitely. I think we have to firstly be careful with how we define triage, okay? Because triage doesn't necessarily mean I'm doing this and I'm going to bring you in face to face and then we're going to discuss what we're going to do. That for me is not how I define triage. I define triage much more in terms of risk management, in terms of serious or not serious, and then if it is serious, how serious is it? Is it actually serious enough to warrant a review today? You know, an urgent review, and that could be with me, or that could be straight to the hospital. So I've seen a number of cases of chest pain where it's clear that actually seeing me today isn't going to change what we're going to do. And that actually the reason I'm triaging this is to show my competency in how I manage risk and escalate it appropriately to negotiate, a patient going to hospital who doesn't want to go to hospital during a pandemic. If I do want to see a patient, and I'm considering actually it's not going to require admission, but it's really there to consolidate my thought processes and to reassure the patient, then that's slightly different, okay? Because the reason I'm doing that is not to be averse to risk, but actually to say the reason I'm bringing you in is because I recognize that actually in order for us to commit to what I think is going on, I do need to do a few baseline examinations, feel your tummy, and if it's a back passage examination, for example, in someone with a change in bowel habit, potentially something along those lines. Now, if all of that is normal, then this is what I think potentially might be going on, and this is how I think we can take it forward. But obviously, if we do find anything, then we may have to go in a different direction in terms of management. So it is, again, I think, just going back to what I said a little bit before, how you start committing to a management plan, how you start committing to risk. So if you're doing a triage consultation only to say, in order to progress with this, I need to see you, and only at that point can we then decide what we're going to do, that's not going to be enough, okay? You have to be saying and justifying, this is the reason why I'm bringing you in, because, and then start sharing your thought processes, because these are the things that we are either considering happening or things that I want to exclude. And if this is what I think is happening, potentially, then these are some of the management options that we can start talking about. And it's just about getting this balance of keeping it very simple, but also sharing with the patient and the examiner your thought process. So again, that IBS case that I mentioned, where it was literally stopped short of just saying, I'm going to examine you, we'll do some blood tests, and then we'll take it from there, is not going to be enough. It's about taking it further a bit more, and that of course is very difficult in a 10-minute consultation. I'm not saying it isn't, but we will mark what we see up to the 10-minute mark. So the more that you're seen to commit and have a discussion, inevitably the more marks you're going to start aggregating.
Are you seeing a trend like the CSA where candidates are not scoring much on the clinical management because they're neglecting the time on that? Or is it different for RCA?
I've seen a lot of consultations which, data gathering still 8.5 minutes, namely because there wasn't good structure and there wasn't the flow. And so there's been a lot of repetition, and patients have then sort of come in at around 6 minutes to express a concern which they had already expressed before. So the candidate has kind of been stung by not really sort of listening and reacting, and then the management has been very rushed, so it's not really shared. It's sort of talking at the patient rather than with the patient. I think the key is recognize that you are trying to manage patients as opposed to diagnoses. So when you do come into that second half, you must readdress the patient's agenda first before you start sharing your own thought processes, because ultimately patients aren't that happy to come in necessarily, especially if their intention was that they wanted to get this sorted over the phone. So you're going to be, again, I say this word justify because it's been highlighted in the RCA so much. You have to justify why you will be doing it. In order to justify something, you've got to share your thought process. So it is about just being very transparent about where you're going.
Yeah, absolutely. I think it's very useful what you're sharing here. And you mentioned some of the pitfalls that trainees are making. If you have to make sure that one thing that trainee gets right, what would that be?
The one thing that you need to, I suppose, get right is firstly knowing what these 16 competencies are, and knowing how to mark them and how to objectively demonstrate them without being formulaic. Now, that's more than one thing, but I think what I've seen is that people who've often come to me who are now have unfortunately failed the RCA have not understood what it is that's actually being looked for here. And as a result of that, there has been a lack of commitment to risk, or a lack of sharing. So as a result, that's really compromised their mark. So understanding what these 16 competencies are and how to demonstrate them is important. I mean, there are basically about 10 things, really, top 10 pitfalls, and I won't necessarily go through all of them now, because I've put slides on the Facebook support group so people can have a look. But the document that HEE has published has also highlighted some of these pitfalls, which are pretty much the same as what I've highlighted, just having observed the trends between the CSA and the RCA. Don't leave it late. Please don't wait until you have access to 1450. You must start recording early. You must start getting used to calibrating your cases and kind of thinking about the challenge of what's coming in, because as mentioned before, if you put in something really easy, it's just not going to be complex enough to hit these 16 competencies. You know, and it's not about finding, and the other myth as well is it's not about finding a really complex patient, because a complex patient may have a very simple problem. Okay, so I think, again, the myth of I've got to find a patient who has lots of comorbidities, okay, but just needs aqueous cream for their eczema. You know, that's a complex patient with a simple problem, and that's not going to meet the grade. Whereas conversely, you know, a patient who comes in and wants an antibiotic for a UTI, that may become complex if you start recognizing there are red flags to that. And actually, rather than just giving an antibiotic, the dilemma of the case is actually recognizing that you might be dealing with something a bit more serious than just a UTI, and how you start negotiating that plan of action. So it's all about having an angle into your case, and the angles really are global competency 2, which is understanding the priority or the dilemma. And I love this. I think you know this because I've spoken to you about this before, but the word dilemma for me is such a powerful word, because it's on the mark sheet. You know, if your consultation has a dilemma to it, it could be an antibiotic negotiation or a sick note negotiation. I've seen a lot of diazepam negotiations. Then that's great, because that is already making it more complex, more high challenge, because it's hitting that global competency too. So those are sorts of cases that can be, you know, they can be used. But if there is no dilemma to the case, then often there won't be a challenge to it. So, you know, what is that dilemma? Is it risk management? Is it a patient who knows what they want as opposed to what they need? Is it about risk escalation or risk containment? Is it about drug dependency? You know, what's the angle, basically? You've got to have an angle to it.
So if I'm understanding you correctly, Nigel, is that when you're sending a case, you need to be thinking what set of skills you're showing to the examiner. Then
yes,
this is how each case has a purpose.
Yes, absolutely. Yeah, absolutely. So, you know, when I'm marking cases, you know, I will watch a case and I will say to the ST, what was your angle here? What were you trying to demonstrate to me, the examiner here? Was it about risk management, risk containment? Was it about being safe versus being over defensive? Was it about you trying to contain risk and not over refer? You know, what was the angle here, please? You know, so that's always the question I ask. What angle are we coming in from here with this as a case, basically?
You mentioned that some of the trainees who've actually not got a good understanding of the competencies on this recording of this consultation, in what areas do you think they're wasting a lot of their time that they could actually use more wisely?
I think one of the issues is just recording blindly, you know, and there's been a lot of wasted time, I think, with cases where, you know, follow-ups have been used, and we know that is just not going to fit the bill, basically. It just won't. So in order to be strategic, you've got to work smart as opposed to just working hard. I think there's been a lot of wasted time in terms of energy consumption. So we're in now the last week of submission, and you know, I'm mentoring about 40 or so STs who are going to be submitting next week, and I can see that they're getting burnt out, because what's happening is they're getting more stressed with the submission coming, and that is pushing them to become even more formulaic. So pacing is very important. You know, if you recognize that you are having a bad clinic and you're not in the right frame, just don't record, is what I would say, because it won't show the best side of you. It's just going to show the worst side of you, and you'll just get more frustrated when you listen to those videos or mark your own recordings. So I think there's been not just time that's been wasted, but energy as well. I think firstly, just have a strategy. Sit down. I would say your reception. I mean, for me, I'm just sharing from my own personal experience. The receptionists became my best friends during the RCA. I would sit down with them at the start of the week to see the patients that had already been, some of them already triaged to come in, who I hadn't seen before, and start thinking about whether I might be able to see those patients. I would negotiate with my trainer to say that this is a clinic that I want to record, and make sure that I gave myself enough time to read through the notes, specifically of the consults which I thought might have a good RCA perspective. So I would make little key points as to the information notes which I could bring into the consultation quickly, rather than having to scroll back through the notes again. That for me saved so much time. You know, there was just I didn't waste a minute that way, basically. I think if you go into it blindly, you're going to waste a lot of time.
I feel the prep before seeing the patient, you're laying the groundwork when you know everything and how you're going to come at it in different angle, and then you do it and show it. Because many trainees at the moment are finding it difficult to know what's the patient coming in with and whether this is going to be a good one or not. So you already pre-select and almost do the groundwork and getting sure that, like, you know all the facts that you need and approach it that way, managing your energy, knowing when is a good case to record and which one just to carry on without recording. Absolutely.
And I think the thing here is try and get your trainers to have a look at your recordings early, but also get, if you are lucky enough to have other trainers in the practice, or actually just other GP partners to have a look. Triangulation is a very important thing, and I think that's, you know, why a lot of people have decided that they you know, I'm seeing a lot of people who've come to me for an extra pair of eyes for marking. Obviously, I don't work for the college anymore. You know, I stopped working for the college back in 2007 because I need to avoid any sort of conflict. You know, and the HE have been clear that, you know, active examiners cannot be sort of marking cases, you know, outside of a college course, or indeed outside of the exam. But, you know, you will still have some of the people's trainers will be examiners, and they are allowed to give input. They can't give you an objective mark. You know, and HE have been clear about this, that, you know, you shouldn't necessarily be giving an objective mark, but you should be clear as to the objective competencies that are being met or not being met. I feel like, you know, the only way that I can get that across is in my own mind to formulate a mark, which is what I do. That's obviously not the guarantee of the mark you're necessarily going to get. But I think when my kind of experience comes from is seeing how the RCA, the old RCA, morphed into the new CSA. And just because I've been doing it so long, I'm confident to give marks. I mean, a lot of people who come on my, for example, CSA course will leave with the predicted mark. And that prediction is often very close to the mark, basically. You know, my hope is that obviously with the RCA, my prediction as to where you should score should also be very close to the mark. But, you know, no one can give a guarantee, unfortunately. And I think that comes back down again to the standardization issue that we've talked about already. But I think if you've got something objective to work to, that's the main thing. You know, if you know where your areas of deficiency are, if you know which behavioral competencies you're falling down on, then it's not just about the case, it's about how you demonstrate that competency within the case. It's important also that you're getting a breadth of stuff. So say, for example, you've already got 2 really good ENT cases, then please don't keep videotaping ENT. You know, if you know you've got two good cases, you know, and ideally we shouldn't be submitting really more than 1 case from any curriculum area. Again, with the July sitting, they were more lenient around that, in which case you could get 2 cases from each curriculum area. We're awaiting final guidance again from the college. But if you've already recognized that you've covered a curriculum area very well, then please don't waste time keep recording that. You need to be spreading your wings and moving forwards with other aspects.
Before we wrap up now, just one question about examination. Sometimes if you have a patient who is taking a long time to get undressed and then get dressed again, are there any prep that would help in these situations, Nigel?
Well, don't sort of rip their clothes off. It's the first thing to say. Yeah. I think that's a really big thing, because this is why I think bringing a patient in face to face, where you're now having to put another minute and a half aside for examination, just think to yourself, is that really going to make the best RCA submission? The college have already said, just from a practical point of view, anyone who kind of exposes themselves with the camera lid on, even if it's just lifting their shirt, you shouldn't use that. Intimate examinations which require a chaperone, no. And they make for good cases, of course they do, but they may not make it for a good case for the RCA. They'll make a good case for a COT or a CBD or your SEPs, but not for the RCA. So I think the only sorts of examinations I would consider doing sort of face to face would be maybe an ear examination, which is relatively easy to do. Having a feel of a lump, like a neck lump or something along those lines. Stuff that's easy to get. But if I'm going to end up doing a full cardiovascular, a full back examination, full abdo exam, it's going to be difficult. Because in the CSA, the great thing is, when you start examining, the examiner will give you your examination findings. I mean, only that could happen for the RCA, where the patient goes, "Oh, here are your examination findings." I was like, "Oh, brilliant!" That doesn't happen. So you've got to start thinking: is that going to showcase your skills, or is that actually going to go against your skills in a way? In terms of the time management. So yeah, it's again strategy.
Right. Any final thoughts, Nigel, before we wrap up?
I think, I guess the first thing I want to say is I think it's been a really tough time for everybody, and I've really felt very sorry for the ST3 cohort who got caught up in this chaos around the CSA and the RCA. So, I want to say well done for just getting through it. And if it didn't go your way, please don't lose hope, because the one thing that you do have going now, if you have been stung by it, is you have the experience of going through the motions of it, but actually recognizing what is being looked for. And the best thing really is you actually have ownership over what you submit, and you have time. The next sitting is in November now. That's plenty of time. Don't leave it till October to start recording. The recording should start now, basically. It took me, 3 months really to get my act together for the old MRCGP. My stuff only came together within the last 2 weeks, really. So start recording, start analyzing your recordings, because the sooner you do that, the easier your life will become. Okay, it can't be crammed for. It can't be crammed for.
Thank you so much, Nigel, for your insights, for your experience. It was very useful, and I'm sure a lot of people watching this video is going to find it useful. You can find more resources at drgiam.com. We'll put a link down below. Thank you so much. And hopefully you'll come back to our show soon.
Oh, anytime, Owen. Anytime. Maybe we can do one on Chinese cooking next time.
I hope you found this video useful. Smash the like button if you found this video valuable, and don't forget to subscribe for new video every Thursday. Take care everybody. Bye bye.